For our final group project, we decided to tackle on the COVID-19 vaccine distribution in Washington, D.C. problem. Our group is Mona, Christopher, Ankita, me, and Laura. And for our introduction, essentially COVID-19 has inevitably affected us all. There have been over 29 million cases in the United States, with over 525,000 deaths. But there is hope on the way. There are currently 2 FDA-approved vaccines, Pfizer and Moderna, and they were developed in a record amount of time. Our third vaccine as well, J&J, was also approved and now is in distribution as well. But right now, our efforts are being focused on vaccine distribution, which is the challenging decision analytics problem. Next slide. So when looking at our decision problem, we set a multi-objective linear programming model. We decided to use the District of Columbia because that is the capital, and we had 2 main objectives as well. We first wanted to minimize the cost of vaccine distribution to the population 65 years and above. They are the most vulnerable population to coronavirus, so they are the most important in initial distribution. Our second objective was to maximize socioeconomic benefit. Due to a wide-scale distribution efforts right now, we wanted to make sure it was fair for the entire population receiving the vaccine as well. But there are also many constraints as well. One of the main constraints is limited vaccine supply, as right now there are only 2 suppliers, Pfizer and Moderna. And then we can move on to the next slide. So when looking for literature on how to solve this problem, we saw a lot of key issues for vaccine distribution. Some of these problems included vaccine sites, vaccine supply, making the vaccine free to the public, moving quickly, there is a 2-week span between each dose, monitoring adverse events such as opening vaccines too early or no-shows at appointments or even catastrophic events, and lastly, most importantly, reaching socioeconomically disadvantaged areas as well. Next slide. So there are multiple distribution challenges when looking at this decision analytics problems. Some of these include procurement of vaccines, equitable and accessible distribution, price visibility, and supply and demand forecasting. But we really wanted to focus on our 2 objectives for our problem because we wanted to only we only wanted to take on challenges that we could take on. Next slide. When looking at more literature, we saw that there were several proposed vaccine distribution models. We saw that there was high risk for frontline healthcare workers, elderly, and adults with comorbidities, which led us to use an age-based model where we picked people 65 years or older, nursing home residents, and also how vaccine reduces fatality rate as well. We also looked at the variable of high contact areas with high spread, or individuals with high contact rates as well. We noticed from the literature review that typically younger demographics reduces transmissions, cumulative number of infections, and incidence as well. And lastly, we looked at literature that addressed socioeconomically disadvantaged people who are disproportionately affected by the virus. This fosters social and racial injustice as well, which is why we wanted to include this variable and objective into our study. Next slide.
We focused on an age-based model for the population group 65 and older, as well as socioeconomic justice model to address the inequality between the wards. Our demographic area is Washington, D.C., with a population of 700,000, split relatively even between African American and white races. The median income is $92,000. In the D.C. area, it is divided into 8 wards with evenly distributed populations per ward. There is significant disparity between the wards socioeconomically. Overall, DC has reported 41,000 positive COVID cases with 1,000 deaths. Next chart. This is a visual of the death counts per ward. Here we show Ward 8 hardest hit with death. Ward 8 is the most disadvantaged ward and reports the lowest median income. Conversely, Ward 2, where the highest median income is recorded and also home of the White House, has been spared with the least amount of deaths. Next chart. This is a visual of the poverty levels for our target population group of 65 years and up. Again, here we see Ward 8, our most disadvantaged ward, has the highest poverty level at 24%. Next chart.
In terms of setting up our model, we wanted to develop variables that would reference the vaccine allocated to each ward. And so that's what we've done with our decision variables here. So we have 8 decision variables, one representing each ward and the number of vaccines allocated to it. Next slide. One of the things we wanted to focus on was the cost of distributing the vaccine as part of our objective. So we split that up into 2 different types of costs: a fixed cost, which would be equal for all locations. And we got numbers from the federal government to set that up. And then variable costs by ward, which were basically set up as was basically based off of the number of hospitals in a particular ward. And wards with more hospitals would have a lower variable cost than wards with fewer hospitals. So you can see we've set up 3 different levels of costs there, from 500 to 1,500 based off that metric. Next slide. So we have 2 objective functions from that. Our first, representing the cost minimization by ward. And so those coefficients for each ward are derived from the variable costs that we set up in the prior slide per ward. So we want to minimize this cost of the distribution to each ward. And then what we did to quantify socioeconomic benefit per ward was to take the number of deaths that have happened in each ward and then reference the poverty level of the senior population, 65 and up population, and then try to quantify, create a monetary value of that based off of a constant we added to that. So you can see those coefficients there. And the goal there was to try to maximize that to offset the cost in each ward. Next slide. The problem also has several constraints, the first of which is the overall allocation of the vaccine to the entire district. So that is at 37,500, and so the total number of vaccines allocated to all the wards cannot exceed that. And then to try to set up a minimum number of vaccine to each ward, we noted that Ward 3, which is one of the wealthiest wards in the city, has had a disproportionate share of the vaccine allocated thus far, with over a third of its 65 and up population already vaccinated. So using that as a baseline, we wanted to have our model focus on areas of the city that had not had vaccine allocated to it thus far in that level. So we came up with a formula to essentially help our model focus on areas of the city with fewer vaccine allocated at this point. And then we didn't want any one ward to receive more than a majority of the vaccine that can be allocated. So we said that no one ward can receive more than a quarter of the allocation, the total allocation. Next slide.
So we use the Pyomo library and the Python Google Colab environment to execute our model. Here is a screenshot of our problem setup. You can see the decision variables at the top with the objective functions designated in the middle and all our constraints at the bottom. Here are our results and the model output. In the left-hand column is each ward. In the medium column is the median household income for each ward. And on the right-hand side, you can see the vaccine allotment designated by the model. Wards 5 and 8 had the highest vaccine allotment at 9,375 vaccines in each ward. Ward 2 had the second highest vaccine allotment. Ward 7, the 4th. Ward 6, the 5th, and wards 1 and 3 with the lowest vaccine allotment. In terms of our objective functions, we calculated our total cost to be the distribution cost minus the socioeconomic benefit. So our distribution cost, after plugging in the values for vaccine allotment per ward, ended up being approximately $36 million. The socioeconomic benefit was calculated to be approximately $29 million, with our total minimized cost being $7,169,892.
For our model, we also wanted to perform a sensitivity analysis as well to account for external events that could potentially happen when vaccine distribution happens in the real world. We ended up using the Salib Python module package as well, and you can see the code over on the right. Essentially what we did was we took all 8 wards and then the bounds created by the initial model and then calculated the sensitivity analysis as well as the confidence intervals from these specific bounds. What we ended up finding out was that there was generally minimal interaction between each of these ward variables in the simulation, meaning that our model is robust and that these numbers actually reflect proper vaccine distribution even if external events were to occur that were out of our control. We can also see like the output on the right show first order sensitivities that are low in value, also indicating that if external variables were to occur, our results would still be relatively similar to what we produced earlier. And we can move on to the next slide to see more. So these are examples of the parameters, the confidence intervals for wards 1 through 8. For the sensitivity analysis, what we did was we split it from wards 1 through 3, 3 through 5, and then 6 through 8 as well to account for the bounds of the package and also for just like for purposes of understanding the results as well. And we can see that the low results indicate that we have a robust model as well. And we can move on to the next slide.
So moving on to a discussion of our model results here. Again, our model was tasked with optimizing vaccine distribution in DC. And as mentioned, wards 5 and 8 received the most vaccines of any of the wards. In terms of ward 5, allocating that much, the model allocating that much vaccine to ward 5, we factored in the low cost of distribution in that ward. And it's also a ward that's more or less kind of a median ward for the entire city. It has a similar median income, it has a similar demographic profile. So it's kind of a logical place to get a significant vaccine allocation. Ward 8, as is mentioned, is the most socioeconomically disadvantaged ward in the city by a large factor. It has a median income that's just over a third of the overall city's median income. And so our model, focusing on socioeconomic benefit, rightfully allocated a significant vaccine to that ward. So in analyzing how it allocated vaccines to these 2 locations, we conclude that our model has functioned appropriately in that way. Next slide.
More about our model. So Ward 2 received a large number of vaccines, and we believe this can be attributed to the low cost of distribution in this ward associated with a high density of hospitals in Ward 2. Ward 7, which is considered to be a socioeconomically disadvantaged ward, received a relatively large number of vaccines as well. And Ward 3 appropriately received a low number of vaccines. And the median household income in Ward 3 is $143,000. In conclusion, our model performed appropriately. There were some vaccine allotments, such as in Ward 2, where the minimal cost was preferred. We believe that this represents real-world behavior. General barriers to vaccine distribution include lack of internet access to make online appointments, flexible work schedules that permit attending an appointment, and transportation to vaccination sites. These barriers will indirectly increase the time, effort, and cost of vaccinating underserved populations. In addition, rapid vaccine distribution is of utmost importance, and vaccinating the underserved requires significant devotion of time and effort on behalf of federal and state governments. Therefore, optimization models may favor vaccination of the socioeconomically advantaged despite implementation of model constraints that attempt to achieve otherwise. Limitations of our model include vaccine hesitancy. So trust in vaccine development is subjective, and we did not account for or measure this in our model. However, it is important to discuss. There's one study from England which noted that 27% of survey respondents indicated that they would probably not or definitely not get a COVID-19 vaccine, even if one were made available at no cost and deemed to be safe. So vaccine hesitancy is certainly a problem in consideration in vaccine distribution. In addition, our model focused on providing first doses of the vaccine. The Pfizer and Moderna vaccines are 2-dose vaccines, and we did not focus on second dosage distribution models. Lastly, a limitation is generalizability of our model. We focused our model on the 8 wards in the District of Columbia, and we realized that the results of our model may not be scalable as vaccination is a nationwide effort. In conclusion, vaccine distribution models vary and raise several ethical questions regarding who should get the vaccine first, how it should be appropriately distributed, and cost of distribution. We herein present a multi-objective linear programming model for vaccine distribution in the metropolitan DC area. We successfully created a model that optimized distribution to citizens 65 years and older, and we achieved our goals of minimizing cost while at the same time maximizing socioeconomic justice. Future studies would include additional GO programming objectives, such as minimizing adverse vaccine reactions, vaccinating populations such as frontline workers, and allocating second vaccine doses. Thank you very much.